Hello everyone, welcome to a new session in hematology. Today we are going to discuss about fragmentation syndromes. As far as undergraduate level is concerned, you should have a very basic idea about what are the fragmentation syndromes, what is microangiopathic hemolytic anemia, and next about thrombocytopenic purpura. So, fragmentation syndrome. So when the normal RBCs, when they are passing through some valve or some fibrin meshwork, these RBCs will break down into small fragments. Am I right? Yes. And because of this, there will be slowing of blood flow. So when the red cells, when they are subjected to mechanical trauma, they may undergo fragmentation in the circulation, and these fragmented RBC may have any shapes. Most commonly, they may be either triangular cells, helmet cells, crescent cells, pointed projections with a lack of central pallor. We call them as schistocytes. Yes, this is the terminology you should remember. Whenever you hear the word schistocyte, the condition which should come into your mind is nothing else but what we call it as fragmentation syndrome, or what we call it as microangiopathic hemolytic anemia, commonly called as MAHA. Okay, so the schistocytes are the hallmark of diagnosis of this group of hemolytic anemias. What group? Fragmentation syndromes. What are the various causes? The most common cause, the first of thing is cardiac hemolytic anemia. That means a patient who has undergone some valve repair like valvular prosthesis, mitral valve disorders, aortic stenosis, coarctation of aorta. Or we have another set of entity, we call it as the most common one that we encounter in our day-to-day practices, that is microangiopathic hemolytic anemia, which has HUS, that is hemolytic uremic syndrome, thrombocytopenic purpura, HELP syndrome, drugs, vasculitis, then any disseminated malignancies or some conditions associated with disseminated intravascular coagulation. A last entity, we call it as March hemoglobin urea, okay, and other acute RBC disorders, okay, yes. So today in this session, I am going to focus myself mainly on microangiopathic hemolytic anemia, in that thrombocytopenic purpura, okay, March hemoglobin urea, HELP syndrome, okay. All these are just, you should know what it is and what is the peripheral smear finding, that's all, okay. There is no need that what you should know about all the aspects, just the key points you should know, because they may ask this as a short note question, so they may give some sub questions in that, and you have to answer, okay. Just at this also, this section will be helpful for you to attempt many multiple choice questions. See, okay. So what about cardiac hemolytic anemia? The most important thing that you have to remember here is, again, what is the peripheral smear finding? You can see schistocytes. Yes. Now let us see what is schistocyte. See, this is a red cell fragmentation syndrome. Okay. Cardiac hemolytic anemia. The peripheral smear, you can see what is the shape of this cell. Yes, what is the shape of this cell? I am going to draw it with a violet color. What is the shape of this cell? It looks like a helmet cells. Am I right? Yes, I told you it may take any shape. Helmet shaped cell, triangular cells, irregular shaped RBCs, anything. Okay, it may be of any shapes. Fine. Yes, so that is red cell fragmentation syndrome. Okay, fine. So in cardiac hemolytic anemia, I told you what are the causes here. Yes, valvular prosthesis, aortic stenosis, mitral valve disease, and coarctation of aorta. In all these, so what is the problem actually? See, the major cause of hemolysis is the mechanical trauma, okay, which is accentuated by the hemodynamic defect due to turbulence in the heart chamber. That means simple, okay. That means what I am going to do, through a damaged valve, I am going to pump the blood at very high pressure. So what will happen? The valve, it will undergo further damage. So the RBCs, fibrin, everything get deposited here. That is responsible for hemolysis. This is basic pathology. Fine? Yes. So you can get anemia, reticulocytosis with a reticulocyte count. It may be some 5 to 40%, and schistocytes or helmet-shaped cells. All these are present. And usually the anemia will be like normocytic, normochromic anemia with polychromatophilia. And since hemolysis is happening, serum bilirubin will be elevated. Now let us shift our focus towards the next entity. So the first entity is cardiac hemolytic anemia. That is one of the causes for fragmentation syndrome. What is the second or the most common cause? The answer is microangiopathic hemolytic anemia. So it is characterized by hemolytic anemia due to RBC fragmentation. So the schistocytes will be more than some 3 by 5,000 cells. Okay, it will have some sharp spicules. Again, reticulocyte is elevated, serum LDH is high. All these are associated. So what are the conditions of MAHA? I told you, typical hemolytic uremic syndrome, or atypical has thrombocytopenic purpura, vasculitis, disseminated malignancies, okay, all these conditions. Fine? Yes. Okay. Now, first of all, we see what is hemolytic uremic syndrome. Okay, see, actually this hemolytic uremic syndrome and thrombotic thrombocytopenic purpura, they are a group of disorders which are not only associated with microangiopathic hemolytic anemia, but they are also associated with some platelet disorders. That means they are associated with thrombocytopenia. So that is why I told you thrombotic thrombocytopenic purpura. So in both these cases, remember, there will be microangiopathic hemolytic anemia, that is MAHA, plus thrombocytopenia, some platelet defect. Okay, so actually this topic can be discussed in platelets as well as in RBC. So I am discussing in RBCs itself. Fine. Yes. So what is HUS? Actually, it is a disease of childhood. Okay. Yes. And whereas thrombotic thrombocytopenic purpura, it most commonly affects the adults. So what all are the components of this hemolytic uremic syndrome? Number one, microangiopathy of the kidney, then microangiopathic hemolytic anemia and thrombocytopenia because of platelet consumption. Fine. Yes. Whereas remember, the major difference between HUS and thrombotic thrombocytopenic purpura or TTP, I won't expand every time. So HUS and TTP, the major difference, HUS is localized. So mainly it affects the kidney, whereas TTP, it may have what a broad spectrum. It may affect mainly the central nervous system. So the patient have neurological manifestations. So what is the basic etiopathogenesis? They will ask you. So it is HUS is usually infection related. What is that? It is infection related. We have two types of HUS. One is called typical HUS and another one is atypical HUS. Typical HUS is what infection is related. That is most commonly associated with the E. coli. We have the hemorrhagic, enterohemorrhagic E. coli, EHEZ. Out of that, we have a strain called as Escherichia coli O157. Okay, this strain is actually most commonly, that is the enterohemorrhagic E. coli, also produced by also we have the sugar toxin, which is produced by the Shigella dysentery. These are the two important toxic strains of the bacteria or infections which are responsible for the hemolytic uremic syndrome. Okay, yes. And what about atypical HUS? Atypical HUS is nothing else but which is mainly because of complement dysregulation. It is triggered by a lot of factors like infections, pregnancies and drugs. Okay, I hope you understand what is typical. Typical means infections, atypical means complement deficiency. Now let us see what is actually the pathogenesis of microangiopathic hemolytic anemia. First, the bacterial toxis in HUS. Okay, it will damage, I told you, so HUS is mainly localized to kidney. So it is going to damage the vascular endothelial cells of the glomerular capillary. So the basement membrane collagen is exposed. So what will happen? I told you, there is thrombocytopenia. How thrombocytopenia is happening? Just listen. So platelets adheres to the collagen because whenever there is an endothelial damage, immediately the collagen will be exposed. Collagen will be exposed. What will come? Yes, just brush up your physiology. Yes, the platelets will adhere to collagen. There will be platelet aggregation. The red cell will pass through this. The red cell will undergo fragmentation. So we will get schistocytes that is responsible for hemolytic anemia. Fine. Or in case of TTP, we have von Willebrand factor multimer. See, normally the von Willebrand factor will be degraded by an enzyme called as ADAMS 13. ADAMTS 13. So this is the enzyme which normally degrade von Willebrand factor. Because of the deficiency of this enzyme in case of TTP, what will happen? The von Willebrand factor won't be degraded. Von Willebrand factor is one of the most important. It's a platelet attractant. So since this von Willebrand factor is not being degraded, it will undergo multimers, it will undergo polymerization, it will attract more platelets. So what will happen? Platelet aggregation again happens. Yes. Sometimes these platelets may activate the coagulation pathway that is responsible for what? Damaging the kidney, leading to increased blood urea and increased serum creatinine. Even malignant hypertension, which is vasculitis. I know what happens in malignant hypertension. Yes, what is that characteristic appearance in malignant hypertension called as? Yes, very good. Yes, the on skin appearance. So it is because of a hyperplastic, it's not hyaline, it's hyperplastic arteriolosclerosis. There will be fibrinoid necrosis of the blood vessel wall that is responsible for platelet aggregation. Fine? Yes. Or in case of disseminated malignancy, you will have cytokines that is responsible for activation of all these cascades. Coming into clinical features, the patient will have vomiting, bloody diarrhea, abdominal pain, dark red urine, sudden development of pallor, and sometimes the patient have acute renal failure. So renal failure, thrombocytopenia, hemolytic anemia, elevated bilirubin, okay, dark colored urine, all this you have to suspect microangiopathic hemolytic anemia. If they have some exposure like diarrhea, blood vomiting, okay, blood in stools, all those, you can imagine the diagnosis is, so what is that? It's a HUS, hemolytic uremic syndrome. See, you can see, what is this? Very good. They are schistocytes. And you can of course appreciate the spherocytes also. Spherocytes. Yes, spherocytes, they lack central pallor. Okay. Then coming into thrombotic thrombocytopenic purpura. Okay, thrombocytopenic purpura. I told you what is the major difference between HUS and TTP. TTP is broad spectrum. HUS is localized only to kidney. Here, TTP, it affects what? Kidney, It affects what we call it as kidney, CNS as well as heart. Fine. Yes. So what is the basic pathogenesis in case of thrombocytopenic purpura? Just remember the enzyme called as Adams 13. Okay, is completely diminished, whereas this Adams 13 enzyme level is complete pure. It is normal in case of us. That is another difference. So Adams 13 is a disintegrin like and metalloprotein is with the thrombospondin 1 like domain. That is an expansion. There is no need you have to by heart this. Just remember Adams 13 is what? Diminished. Okay, yes. Sometimes if this Adams 13, no, it is inherited. Usually this is a microangiopathic hemolytic anemia, thrombocytopenic purpura. They are acquired conditions. Suppose if this Adams 13 deficiency is inherited, we call this condition as Upsha-Shulman syndrome. What is the name of the syndrome called as Upsha-Shulman syndrome? So I told you what is the problem here. The von Willebrand factor degrading enzyme is absent. Von Willebrand factor, what happens? It forms what we call it as von Willebrand factor multimers. This is responsible for platelet aggregation. Then again the whole pathway is going to continue. Fine. Yes. And this TTP also occurs in case of pregnancy, malignancy, bone marrow transplantation, drugs like acyclovir, quinine and platelet aggregation inhibitors. Okay, all these drugs may cause what we call as secondary TTP. Fine? Yes. So the clinical features, remember children, what is the triad of hemolytic uremic syndrome or has MAHA, thrombocytopenia, renal function abnormality. That triad plus fever and neurological signs. So triad plus 2 becomes pendad. So MAHA, thrombocytopenia, renal function abnormality, fever, neurological signs and symptoms. I told you, HUS is localized to kidney. There is no problems in any other system. Whereas in case of TTP, it is generalized. It is mainly going to affect the CNS. It will have fever. Okay, there will be kidney lesions. Everything will be. So it's a pendad. But remember, only 40% of the patient has this typical pendad. Okay, yes, the patient may have confusion, delirium, altered state of consciousness, hemiparesis, and thrombocytopenia is also there. So the patient may have purpura and ecchymosis. Again, what is the hematological finding? Yes, serum LDH will be markedly elevated, schistocytes will be present, serum haptoglobulins will be reduced, hemoglobinemia, hemoglobin urea, hemosideruria. Okay, yes, the platelet count is 10 to 15 to 10 to the power of 9 per liter, whereas it's actually a platelet disorder. So the coagulation pathway will be completely normal. So PT, APTT and INR will be normal. Okay, because it is a platelet counting disorder, not a coagulation disorder. That is a very, very important. And Adams 13 level will be poorly diminished. It will be less than some 5%. What are the differential diagnoses you have to think of? Systemic lupus erythematosus, the most important, the first thing when you suspect TTP, the first thing you have to rule out is HUS, because TTP and HUS mimics clinically, they mimics in the periphery smear. The gold standard test to differentiate between these two is Adams 13. Adams 13 enzyme is completely normal in case of HUS. It will be diminished less than 5% in case of TTP. Then another differential diagnosis only you have to consider like SLE, number 1. Number 2, you have to go for antiphospholipid antibody syndrome. Okay, yes. And next we have something what we call it as March hemoglobin area. What is March hemoglobin area? So marching, that means it occurs in athletes and soldiers who following strenuous exercise or marching long distances. So because of that, there will be mechanical destruction of the RBCs in the feet capillaries. So there will be a transient hemoglobinemia and a hemoglobin urea. Fine, yes. And again peripheral smear will show fragmented RBCs with the polychromasia. Then what are the other causes I told? Disseminated malignancy, pregnancy. How is pregnancy related? See, in pregnancy, they have a condition called as pregnancy-induced hypertension, pre-eclampsia and eclampsia, which occurs at 32 to 34 weeks of gestation. You know, pregnancy itself is a hypercoagulable state. There will be it's a high output state. Am I right? Yes. So all these features, suppose, see, usually this HELP syndrome is not seen in all pregnant ladies. Suppose in pregnant ladies who are having severe hypertension, severe eclampsia, they may present with HELP syndrome. What is the HELP syndrome? Expansion, hemolysis, elevated liver enzymes, low platelet syndrome. So again, it's like a thrombocytopenia. You should know the expansion. They may ask this in MCQ. Hemolysis, elevated liver enzyme, low platelet syndrome. This is associated with which of the following hemolytic anemia? The answer is fragmentation syndrome or microangiopathic hemolytic anemia. Okay, this is a very frequently asked multiple choice question in Central Institutes exam. Okay, yes. Then mitomycin, bleomycin and donorubicin. All these are what is the chemotherapeutic drugs. They may also cause microangiopathic hemolytic anemia. Fine, yes. And I told you, vasculitis. Fine, vasculitis. Okay. Like SLE, polyarteritis nodosa and vaginous granulomatosis. So in this video, we have to see this is the smear of thrombocytopenic purpura. We can see again what is this helmet-shaped cells. You can see the fragmented cells. You can see the fragmented cells, helmet-shaped cells. Okay, helmet-shaped cells you can see here. Okay, and polychromasia. Reticulocyte count is raised. You see the platelets are not seen. How will you see platelets? Platelets will be seen like these bluish dots. So these are platelets. This is how you will see platelets in peripheral smear. These are completely absent because it is thrombocytopenia. Okay, see the count now. The level of platelet is 10 to 50 into 10 to the power of 9 per liter. What is the normal platelet count? 1.5 into 4 lakhs per cubic millimeter. Here we are seeing 10 to 50 into, that means it is around the range of 10,000 to 50,000. So normally it's 1.5 lakh to 4 lakh lakhs. Here we are getting 10,000 to 15,000. Okay, yeah. So remember, it's not a coagulation problem. It's the problem is in the platelet clumping. Adam's 13 level is diminished to less than 5%. So in this video, we have discussed about fragmentation syndrome. You may get any of this or the fragmentation syndrome as such. You may get in case of as a short note question. So thank you.